Good afternoon, everybody. I welcome you all for this organ donation committee of Indian Medical Association Tamil Nadu State Branch meet the organ donation CME 3 today. We are just now going to start the program, and now I welcome Dr. Sivaprakasam to give the physician's prayer and IMA prayer.
Sir, good afternoon, sir.
Yes, boss.
IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May be the healing cure beyond every weight and lure. The physician prayer. Dear Lord, the great physician, I kneel before thee. Since every good and perfect gift comes from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength of lift at least a part of the burden of my suffering fellow men, and a free and a true realization of the rare privilege that is my take from my heart all the guilt and worldliness. That with this simple faith of child, I really on thee. Thank you, sir.
So now it is time for the welcome address. Good afternoon, everyone. As the chairman of the organ donation committee, myself, I welcome you all. I welcome our president, Dr. K.M. Abul Hassan sir, our state secretary, Dr. S. Karthik Prabhu sir, and our finance secretary, Dr. Gauri Shankar sir. And I also welcome our past state president, Dr. Sendabil Pari sir, and the state president-elect 2024, Dr. P. Sengutuvan sir, and Dr. B. Sridhar, the state president-elect 2025 sir. And also the speakers of the day, Dr. T. Saravanan, Dr. M. Ramalingam, and the panelists, Dr. K. Sendil, Dr. N. Balakrishnan, nephrologist, and the program organ donation coordinators, Mrs. Devi Subramaniam and Mr. Mohammed Sahir. It is indeed a great pleasure in inviting you all for attending this program. The main aim of the program is to give more awareness about the organ donation. That is the main aim of doing this. And the organ donation committee of IMA Tamil Nadu for the year 2024 as created by our president, myself, and this organ donation emblem we have created. In this we can see the organ donor emblem is also incorporated in that in between the IMA. And these are all our team members, Dr. Kalidas, Dr. Sivaprakasam, Dr. G. Srinivasan from Karur, and Dr. Papaya from Madurai, and Dr. Kanagachala Kumar from Erode, and Dr. T. N. Saravanan from Erode. He is the secretary of Erode, and Dr. G. N. Suguna from Attur. The main aim was to give awareness about the organ donation. Each and every month we wanted to do that. And I request all the president, secretary, and finance secretaries to participate in the program and send and communicate the emails to all the members so that all the people will attend. And we are going to conduct the periodic organ donation awareness meetings. Now the time for the election now, so we will not be able to conduct any program. And we are going, after the election only, we are going to start the programs we want to conduct in medical colleges, nursing colleges, and engineering colleges, and Rotary clubs, and Lions club, and forums. And these are all the two handouts which we have created. The English handout one, and another one is the Tamil handout which we have created. And we have circulated among all the branches. We have given to all the people, most of the people. And we have also requested all the branch president and secretaries to print similar forms with their logos and their photos and distribute among the public. That is the main aim. And to increase the awareness, if a person with a brain death donates the organ, the branch IMA office bearers, please meet the relatives during the funeral or after in their home and thank them by giving a citation. And in the IMA meetings, in the periodic meetings, what they are conducting, I request all the president and secretaries to give minimum 5 minutes to be allotted to talk about the organ donation in each meeting in the form of show the PowerPoint presentation about organ donation. If there is any organ transplant or specialist in their branch, request them to talk about their experience during the month, and if not available, we can invite from nearby branches to give the talk. Show the waiting list of the organs necessity to obtain list from the transplant and show it to your member meetings. To observe 1 minute silence for the brain death donors in their region. And we wanted to conduct the regional organ donation awareness workshop to college students, paramedical staffs, doctors, so that all the procedures can be explained in detail, educate more people. And we like to conduct a hospital coordination meet to conduct regional donor hospital coordination meet by inviting donor, recipient and transplant hospital doctors and conduct a meeting once in a month with the organ donation committee members of IMA TNSP. To spread the message of Transplant. Transplant is the main body, the Transplant Authority of Tamil Nadu. Request all the IMA members to visit at least one time to that website to know more about the organ donation. This is the organ donation emblem which is being created. And it is in our website also we can register our organ donation, imatn.com. And the process is given. We have to click it in the IMATN. And on the right hand top, applications, organ donation volunteers, and then IMA TNSB organ donation volunteers, Google form, fill up and submit, and you will be given a card later. Separate Google form will be created and sent to the public that we are on the process. And this is the organ donor card which is being issued by the Transplant. And this is an example of the card when finally we donate. See, this is my name, it is registered and organ donor card, and in this all the organs and everything and contact person in need, they have written the number also. And in this month, actually the Erode IMA, the Women's Day Kidney Donor, the Abhirami Kidney Care in association with Erode Indian Medical Association celebrated International Women's Day by felicitating the women kidney donors for their selfless motive in presence of Erode IMA office bearers and senior IMA leader Dr. C.M. Rajasa. The Kidney Disease Awareness magazine was released in the function, and Dr. Saravanan gave a talk about the organ donation and felicitated the people. And this was the some of the clippings. And to increase the awareness about organ donation, awards for the good performance that we got approval from our president. Thank you, President Sir, for the branch with maximum donor registration in our website, and to branch conducting maximum donor awareness meetings to be given during the state conference. So I request all the branch presidents and secretaries and treasurers to actively participate in these programs and get their awards. And one more thing is a pamphlet which I was telling. The Erode IMA released a handout from their branch for the organ donation. This is how they put it, and it is very nicely they have circulated among all the IMA doctors. That's what I have done. The message for the March, there was a hand donation. The Delhi's first ever bilateral hand transplant helps painter gets his hand back. Here, a painter who has lost his both the hands, and for him the hand transplant is being done. That is I wanted to show you, because this has happened on 6th March 2024. That's why. And another thing is one skin donation. My mother's sister's husband died on 21, that is my Sitapa, on 21/3/2024 due to old age at home. Immediately, I have arranged for eye donation and skin donation at their home. This is the 5th such skin and eye donation I am arranging in these 2 years. And then we can, now we will have the presidential address, inauguration of the program.
Thank you, Dr. Rajesh. Respected Under Secretary Dr. Karthik, Finance Secretary Dr. Gaudi, and all the office bearers of IMA, and also the members of transplant organ donation committee, Dr. Saravanan and others, and today's faculties, Dr. Ramalingam, apart from Dr. Saravanan, Dr. Ramalingam, Dr. Sendil, Dr. Balakrishnan, Mrs. Devi Subramania, and Muhammad Shakir. I wholeheartedly thank you all for joining this wonderful seminar today. And I am very happy that the Organ Donation Committee of IMA Tamil Nadu State Branch is living up to the expectations. And I can even go to the extent of saying that this kind of activity is happening in full swing in Tamil Nadu state when compared to all other states. So I am very happy that we will, at the end of the year, we will come out with a very strong, perceptible changes in the area of organ donation, with the number of organ donors also increasing from meeting to meeting. As Dr. Rajesh said, we will be definitely giving away awards in the coming conference in December for the branches who are bringing out maximum number of organ donors and also maximum number of organ donation awareness committee. Having said that, you all know that this is one of the important area and even is one of the important landmark development area in modern medicine, that we are giving life to many patients who are suffering from end organ diseases. I think so. It is the duty of all of us to carry this message and live like a torch bearer for transplantation. Any specialty doctor, it is our duty to carry this message, and first being an organ donor ourselves, and then spread the message to other people. So it's very, very important that so many people are waiting for organs. When compared to India, there are other countries, the neighboring countries like Sri Lanka is far ahead in their organs.
260.
So I think IMA should take up this. That's why we have formed this committee, and we should be number one in the world in the area of organ donation. Already Tamil Nadu is leading the number of organ transplantation, and we have to go far ahead to kind of in the number of organ donors, the number of organ transplantation happening in our state, and also become number one in the entire country. I'm very happy also that last time I had been to Dr. Saranan's hospital of Brahma Kidney, where the handbill was released, and I am very happy that we had identified right people for this job for the organ donation. As Tirukural says, இதனை இதனால் இவன் முடிக்கும் என்றாய்ந்து அதனை அவன் கண் விடல். Like that, the team is very much actively engaged in this, and I wish them all good luck, and we should come out with the flying colors in the sense that we produce more organ donors, we conduct more number of awareness meetings across the state. There should be a perceptible change in the mindset of the people of Tamil Nadu at the end of this year about this organ donation, particularly for the cadaveric organ donation. So I wish the team all success, and I thank the organizing committee for giving me this opportunity. Over to you, Dr. Rajesh.
Thank you for your kind words, sir. Thank you for allotting awards to the branches, sir. Now I request our past president, Dr. Sendamil Pari, sir, to give his felicitations. Sir is not joined, I think. Now I request our president-elect to 2024, Dr. Sengutuvan, sir, to give his felicitation.
Good evening to everybody. I'm really very proud about this organ donation committee meeting that are doing a wonderful job for the CME program. Respected President, Secretary Dr. Karthik Prabhu, Treasurer Gauri Shankar, and Organ Donation Committee Chairman Dr. Rajesh Babu, Secretary Jayaraman, and other dignified members. Thank you for the opportunities. Regarding the CME, Dr. Rajesh Babu is doing very wonderful work by making all the effort to make this program as a successful one. I like that his interest in the organ donations and everything, academic medical specialties, and also he is doing very great job for this program. So I wish him all success and my sincere thanks to the speakers of the day. Thank you, sir.
Thank you so much, sir, for your kind words. Now I request Dr. Sridhar, sir, to give his felicitations. Sridhar, sir, is not there. Now I invite Dr. Karthik Prabhu, sir, our State Secretary, to give his felicitations.
Good evening, everybody. Most respected President, President-elect Sir, Rajesh Babu Sir, and all team members. I congratulate you for the next meeting of this series of organ donation, which is very, very important. And I'm sure with your intervention and many such meetings, sir, many of us can motivate our people to go for organ donation, where many will be definitely benefited. Best wishes and good luck for your all endeavors. Best wishes, sir. Thank you.
Thank you so much, sir, for your felicitations. Now I invite our Finance Secretary, Dr. Gauri Shankar, sir, to give his felicitations. Gauri Shankar, sir. So, sir is not there, I think. Dr. T. Saravanan, sir, Senior Nephrologist and President of the Erode IMA and a transplant physician, to give his talk.
Good afternoon to all the IMA dignitaries on the meeting, and good afternoon. My regards to Tamil Nadu State President Dr. Abulasan sir and Dr. Karthik sir and other dignitaries. And first of all, I have to thank Dr. Rajesh for taking efforts in organizing this meeting in such a way so that everyone in the community knows many things about donation. And when we compared our Indian country with Western countries, the number of cadaveric transplants is 90% in US when compared to live related transplants in US. But in India, the number of live donations and live transplantation, that is kidney donation from a live related donor, is higher when compared to the cadaveric donors. Here, 90% it is 80 to 90% of the transplantations, kidney transplantations that happens in India is from a kidney that is donated by a related person. It is exactly opposite in Western countries. The reason we are far behind the Western countries in declaration of brain death and motivation of the patients, and then conducting a kidney transplantation from a brain dead donor. So my talk is going to be on that. And to be introduced, I'm a present Erode IMA president, and I'm also part of a nursing home board and an organ donation committee in the Tamil Nadu State IMA. So when considered, transplantation is the best therapy for end-stage renal disease. So live-related transplant is 95% success rate, and deceased donor transplant is also coming to 90% success rate. But it is marginally lesser when compared to live-related transplant because there is no matching among the patient and the donor in deceased donor, because we don't know which patient is going to donate, and the matching will be less in deceased donor transplant. And this is the reason for the for the 5% decrease. And the overview of my talk: indications, benefits, and contraindications, and how it is conducted in Tamil Nadu, and what are the legal points and take-home messages. So for a patient CKD, if a patient is on dialysis for any reason for more than 3 months, and if patient is not having any reversibility, that patient should undergo transplantation for him to be possible to go back to his life. Because undergoing dialysis, either it is home dialysis or hemodialysis, it will be difficult for them. And the success rate and 94% it's there in 5 years, and deceased donor, it is when it comes to 5 years, it is coming down to 76%. So the indications for transplantation: end-stage renal disease, dialysis dependency for 3 months, and contracted kidneys, and when the kidney size is less than 8 centimeters and age less than 70 years. But nowadays, with the present improved medical infrastructure, even transplants is possible for more than 70 years of age. So where all can we get donors? So deceased donors is something who is donating after brain death. If the patient gets a road traffic accident and then patient is declared brain death, and this is what we are doing around 90 to 92%. And donation after cardiac death is also possible, and it is conducted in Western countries with some machines that they are able to perfuse the organs in a better way, so that that can be possible in Western countries. But in India, we are doing donation after brain death is what that we follow. So the survival benefits: why should a patient on dialysis patient undergo transplant? So if you look at the green line here, around 5 to 10 years, there is a lot of mortality that is happening. So percentage of survival is grossly reduced once a patient continues to be on hemodialysis. Suppose if the same patient has underwent a transplant, we were able to safeguard their lives in a better way. So this is the reason why we have to do transplant. So lesser mortality, better quality of life, better rehabilitation, and mostly in fertility. So suppose if we get a case of 25 years, 26 years, male or female, who has been recently married, this patient has been diagnosed to have kidney failure and he is on dialysis. He or she, their fertility is grossly reduced with any form of dialysis. That is not due to dialysis, it is due to the hormonic changes that happen because of chronic kidney disease. So once the creatinine is reduced to 1 milligram per deciliter, that is what the usual outcome we expect in transplantation. So within some 2 to 3 days, you get the creatinine back to 1 milligram per deciliter, which is the normal range. So at that point, their fertility is regained. So the contraindications for transplant: reversible renal failure, any active infection. Suppose if the patient's CRP is more than 100 or procal is positive, then we cannot do transplant in that patient. And recurrent native kidney disease. So this is where the renal biopsy is very much useful. And malignancy, active malignancy, non-compliant patient, untreated coronary artery disease. Nowadays, we have started performing conventional coronary angiogram to clear a patient for transplantation to avoid these CAD problems during the transplantation phase. And untreated chronic hepatitis. So suppose if a patient is chronic hep C positive, and this hepatitis C viral RNA should be cleared with the oral antiviral therapy, and the patient should be in sustained virological response. That is, we give the medicines for 3 months, and then we take the HCV RNA. That HCV RNA should be cleared, and then we have to recheck without medicines for 3 months. So after 6 months of medicines, these patients, chronic hep B and C, can be cleared for transplant. So this is the usual recipient workup that we do: hemogram with iron studies, RFT, calcium, phosphorus, PTH, coagulopathy, PTA, PTT, serology, and protein creatinine ratio, Mantoux test to rule out any occult TB, chest X-ray, ECG, and males more than 50 years, prostate-specific antigen. And for all females, we usually perform pap smear and mammography. So for cardiology clearance, if it is low risk, if it is less than 40 years, EF is normal, no residual wall motion abnormality, then they can proceed without a conventional angio. But if the patient is a high-risk individual, wherein 40 years, diabetes, coronary angiogram is a must. If there is CAD, revascularization is advised. But usually this PTCA, that is keeping a stent in the heart or doing an open heart bypass surgery, will be very much hesitant by the patient, and that is left to their own discretion. And in the recipient workup, we usually put in upper gioscopy to look for any esophageal or candidiasis, and then liver function test and pulmonology clearance is sought, and urology and the iliac arteries, both artery and veins Doppler is done. So this is the immunology workup that we do. We usually do HLA typing. If the patient's related donors, suppose if the father is giving to son, this HLA typing will be matched for 50%. So we expect a haplo match, that is 50% matches in A, B, DR antigens. So suppose if there is a deceased donor alert, suppose if we are in the middle of the night, if we get a call from the transplant about our waitlisted patient, that our recipient will be immediately called on to reach the hospital, and we will usually take the blood and send an ambulance to send a cross match with the donor lab. Suppose if the patient is in West Zone, is comprising of 4 main districts, and Erode, Coimbatore, Salem, all Tirupur, all comes under West Zone. Suppose if a donor is there in Salem district, suppose if the alert is coming to our hospital in Erode, we will usually call the patient immediately to our hospital and get a cross-matching blood, and that will be sent to the donor side lab of Salem, and then there the cross-matching will be done. Only based on the cross-matching, the allocation list will be confirmed by the transplant. So which will be in future slides, you will be in a position to see. And if there is a history of failed transplant, suppose if we are going to do a retransplant, then panel reactive antibody titer is tells us how immunogenicity that the patient has. Suppose if the panel reactive antibody is positive, then if the cross match may turn positive, and a patient may land up in antibody mediated rejection, which may affect the grafted kidney. So these cases, we will usually subject them for desensitization protocols before transplant, and only then they will be cleared for transplant. So this is the Transplantation of Human Organs Act and its provisions. And brainstem death was accepted, and only living related donors can donate kidneys without legal problems. The first degree relatives are encouraged, and father, mother, brother, sister, wife, children. If the donor is a wife, the marriage should be completed before 5 years of the present date, and marriage certificate will be asked for, and we will be submitting all these documents to the HOTA committee, and then we will be getting the clearance before transplant. So, and for unrelated donors, permission from authority is required prior to surgery, and usually this permission will not be granted, and the committee will be verifying all the any financial handouts was happening during the transplant. If there is something is noted, they will be rejected from the committee, and the transplant cannot be completed. So it requires regulation and registration of hospitals. So not every hospital can do transplant. We have to develop the infrastructure. We have to get an application to the committee, and then the team of nephrologists will visit the hospital and clear the hospital if there is good infrastructure for the hospital. Otherwise, the hospital cannot do transplant. And there is a punishment for all commercial dealings in organs. And this is the donor workup that we usually do. If it is a live related donor, the first step is blood group, RBS. The group matching is advised. And then even now we can perform ABO incompatible transplant with the help of plasmapheresis. And they usually ultrasound abdomen to look for any 24 hours urine collection for proteinuria and creatinine clearance is one essential step to be followed, because that gives us the exact measurement of the kidney's function. So the final step in a living related donor is the cross match and CT angiogram. The CT angiogram is done to verify what is the number of arteries and veins on both sides. So which kidney can be planned to be donated. And DTP renogram to assess split renal function. So these are the usual referrals, and nowadays the psychiatric clearance is also sought for all living relative donors, and gynecology clearance and urology clearance, and there will be a transplant meet that will be conducted by the nephrologist, urologist, and the anesthetist, and the vascular surgeon team, and the nursing in charge to get ready for the transplant. So cadaveric transplant is usually harvested from a brain dead donor. This TNOS is what that we call now as transplant, and it is a government-run body. Registration of a dialysis patient is a must. So when can we register a patient in transplant? Yes, the patient should be started on dialysis, and the dialysis should be for more than a period of 1 month to 3 months. Only then the patient can be registered, and the patient cannot have dual registrations. If the patient is registered in one hospital, then the patient should be registered only in that hospital, or he can be transferred to other hospital, but one person with one other ID cannot be registered in two hospitals. Because as a professionals of medical profession, you will be encountering with all these queries from your families or your friends that whether I can register in some 2 or 3 hospitals, because the dialysis patients will be very much desiring to get a transplant when they have taken a decision for transplant. So they will be finding all the shortcuts to get a transplant done if they don't have any related donors. And organ allocation is done exactly according to the seniority, and the role of transplant coordinator role is very much. And this a DD is now 3,000 rupees in the favor of transplant should be taken, and unique ID will be given to the patient, and they can verify their seniority in hospital and in the zone pool in any browsing center, and even in their own phone they can check their two seniorities. So it is 100% legal, and already for the 6 consecutive years, our Tamil Nadu Transplant has been successfully doing the highest number of transplants. So this is what I have been talking about. So we are into the west zone. Coimbatore, Erode, Salem is all comprising in the west zone, and the south zone is with Tiruchirappalli, Tanjavur, Madurai, Tirunelveli, Nagarkoil, and the north zone is Chennai, mainly Chennai and Kanchipuram and Velu. So the basic principles we have to, how can we have a successful cadaveric organ donation and transplant? We have to identify all the potential donors, and early confirmation should be done for all brain dead patients, and consent should be obtained, prompt notification of the retrieval team, and careful and intensive management of the donor. This is very, very important, because if the donor is not fit to be donating at the time of the surgery, and that actually there is a wastage of the organs, and rapid retrieval of the organs also should be planned. And the etiology, the usual etiology is severe head trauma and cerebrovascular injury and prolonged cardiac resuscitation or asphyxia and tumors, but there are other reasons also nowadays. So what is brain death? It is irreversible loss of all functions of the brain, including the brainstem, with a beating heart. So this is how you have to evaluate. And then if the patient is deeply comatose, and then you have to, if there is a suspicion of brainstem death, you have to exclude hypothermia, drug intoxications, endocrine crisis, and severe electrolyte acid deficiencies. So after excluding, and even then there is absent motor response, and absent tasting reflexes, and apnea with apnea test should be done, and apnea test if the PCO2 is more than 60, and even then there is no motor response or brainstem reflexes, then you diagnose brain death, and then you have to tell the attenders that there is a possibility for you to donate because it is irreversible. And this confirmatory, if the patient is, if there is not able to perform all the elements of clinical examination, suppose if the patient is not tolerating the apnea test, if the patient is having hemodynamic instabilities, then there is something called ancillary test. And by doing a transcranial Doppler, if you establish absence of cerebral blood flow in both of the middle cerebral arteries, then that diagnoses brainstem death. And even EEG can support this diagnosis. So absence of brainstem reflexes, there should not be any pupillary reflex, absent corneal reflex, no gag reflex, no Doll's eye test, and ocular vestibular testing, ice water irrigation to each canal. So, brainstem declaration, I will not go into the brainstem death possibilities because the last month it was very finely elaborated by our speaker. And so it is a So the brainstem death, you need very detailed documentation. So you have to document each and everything in your case sheet, and there should be a gap of 8 hours between the two apnea tests that you perform in the hospital. And that Form 8 has to be certified, signed by the empaneled doctors. I will tell about it in the future. And the donor criteria is normal. Kidney donor criteria is age less than creatinine, serum creatinine should be normal, no CKD, and serological tests all should be negative, no sepsis and malignancy. This is the ideal cadaveric donor. But even if the age more than 65 is also accepted, but the percent more than So the next is the consent and prompt notification of the retrieval team and careful and intensive management of the donors. So for successful donor transplant program, the members of the committee will be anesthetists, coordinators, tissue cross-match facilities, retrieval team, transplant team, and theater and ward dialysis unit and ICU staffs. So all these things should be there for successful cadaveric transplant committee. So these are the changes that happens actually. After a brain injury, you get cerebral ischemia, and that brain death will trigger all the sympathetic response, parasympathetic response, pituitary dysfunction, and pro-inflammatory release and coagulopathy. Because if you are not going to manage all these things in a correct way, then these things can affect the functionalities of the organs, and the organs may not be in a position to utilize at the time we plan for harvesting. So it is a very crucial time, and all other things has to be managed by an intensive care facility team for us to conduct a cadaveric transplant. And first of all, the blood pressure has to be maintained, and the mean arterial pressure should be more than 70, and heart rate should be more than 6. We have to maintain it between 60 to 120, and urine output at least 3 ml per hour should be there per kg. That is, if 60 years old, 60 kg man is getting admitted, the urine output should not be less than 50 ml per hour. That is the lowest threshold that we can use. And hemoglobin should be 8, and renal wise, you have to maintain euvolemia. It is better that you give the fluids based on the IVC, and doing an IVC chart of once in 6 hours, you can get to have information about the patient's intravascular volume. And thyroid hormone replacement is usually advised. And if this triiodothyroxine IV is not possible, then better you give only thyroxine. Maybe 200 microgram orally through the rice tube, you can be giving it to replace the endocrine functionalities. So this is the apnea test. The performed after all the criteria is done. The core temperature should be more than 36. Systolic blood pressure should be more than 100. And eucapnia and absence of hypoxia, all is necessary. And euvolemic status is also necessary to conduct an apnea test. So the suppose if apnea test is, you have to disconnect the ventilator and wait for the PCO to reach until 60. And if there is any hypotension, hypoxemia, and cardiac arrhythmia, then you have to abort the test, and this may suggest inadequate oxygenation or pre-oxygenation. And complications of 10 to 20% is possible in this. So this is how the organ retrieval and the stenotomy and the midline laparotomy is usually done without bilateral extension. And this is how the organs will be perfused. And as a nephrologist, we will be very happy if the liver team is using the liver transplant, because they do the in situ perfusion in a very good way. They use this University of Wisconsin solution or some other solution. They will be doing it for in situ perfusion even before they take the organs out of the body. So when we receive the kidneys outside, yeah, it will be given en bloc with both the kidneys. And if we receive the kidneys in a white color, then that tells that patient has they already been perfused by the in situ perfusion in a very good way. So if the kidneys are not perfused properly, suppose if the liver team is rejecting the liver donation, that is liver organ, then the perfusion of in situ perfusion will not be there. In those situations, it will be tricky for the nephrologist to complete the perfusion after it has been removed, because we were not usually performing this in situ perfusion for only kidneys. In situ perfusion was done only for the liver transplants. So the principles of organ preservation, and we have to maintain hypothermia, and that is how it should be packed actually. And then we have to we have to take steps for prevention of edema and acidosis. So how organ preservation is done is metabolism will be very less at that 4 degree, and the ideal temperature should be around 4 degrees centigrade. And these are the usual solutions for prevention of acidosis, etc. This is what has been used. Eurocollins and University of Wisconsin has all these contents in their solutions, and we usually use this HTK solution. And all these things are used to prevent or to minimize the ischemia reperfusion injury. So in situ hypothermic perfusion and packing of the abdominal cavity with ice will reduce the core temperature of the patient, and thereby it will reduce the core temperature of both the liver and the kidneys. And then lower aorta is immobilized and heparin was used, and aorta is cannulated, and suprarenal aorta is clamped and perfused with cold perfusion saline. And this is how the in situ perfusion usually happens during the time of harvesting. So kidney removal happens after liver removal, and this should be usually given as a en bloc kidney. And then back table perfusion will start, and there will be 2 sets of perfusion for the kidneys. One is in situ, and then one is at the back table. And then we usually perfuse the kidney by using the RL with papaverine or some available solutions like HTK and custodial or Graftsol. And we usually use a vessel tip for, we usually make the solution very cool, and then we give the solution in the artery, and we look for the clear solution to come out through the renal veins. And once it is done, then we will complete that 1 liter of perfusion, and then we will bury the kidney inside the slush of the ice, and then that will be given to the surgical team for implantation. So this is how it should be packed actually. The organ packing should be done with a 3M cover, and this 3M cover has the specific thread-based thing that you can tie it up, and then you have to put it inside the ice slush, and then the organ can be transported to other hospital if the recipient is admitted in other hospital. So this is how the transplantation is done. The incision is done in the right hypochondrium. The skin subcarinous tissue is mobilized, and then the gap is created for the kidneys to be anastomosed to the renal artery and the vein. And the bladder, the ureter anastomosis will be completed. And actually, there are protocol development is already there, and there should be motivation and persistence of motivation for the families of the brain dead donors for it to be completed. So what are the type of brain dead donors? Mostly it is road traffic accidents and spontaneous ICH, brain malignancies, and poison donors are the usual things. So indications for possible brainstem death. Suppose if you have a coma patient in your ICU, when will you suspect brainstem death? Diabetes insipidus, when the urine output is going 150 to 200 ml per hour, and the urine is like water, then you suspect brainstem death. And unexplained hypothermia and hypotension can also be a brainstem death suspicion event. And clinical criteria, examination criteria, and apnea test. If all the things are positive, then you can conclude that patient to be brain dead. So this is the transplant that we have been speaking on, and this registry and the username password will be given to the hospitals that had already been registered. And this is how we register the patient in the transplant. If you see this, we have to and check for the donors availability. If usually we will receive an alert call from the transplant team if our patient is on the higher waiting list and if we have to update our response. So once if you are going to have a donor in your hospital, suppose if the patient has given consent for donation, then immediately you have to intimate that to transplant, and then you have to update certain forms about the donor's blood tests and etc. And then you have to update it in the transplant. So you have to fill up the investigation and consult column with transplant guidance. They will be sending you a PDF. You have to complete the PDF, and then you have to add new donor and inside this page of transplant, and then you have to start working for that. Suppose if you have. And then this update form number 8. This is the important form, and that tells about the patient's name and the relative's name. And then you have to get a signature from the near relative to the donor. And then this is the certification of brain death, that is form 10. So in this, you see 4 signatures. Of the 4 signatures, at least 2 and 3 should be completed by the empaneled doctors. This not all doctors or not all neurologists and neurosurgeons are empaneled with the transplant, and you have to the hospitals will get empanelment for some certain patients, and then certain persons to declare, and then the empanelment number has to be mentioned at the time they sign this. So one organ allocate for in-donor hospital if there is in-house recipient, the others will go for the donor pool. And this is the police intimation form that we have to complete before moving the donor to the surgery. And then at that time, before police intimation and police clearance, no hospitals can move the donor for surgery or organ harvesting because that is a illegal thing, and that is a that will produce a problem. So we have to get the police personnel to our hospital to get the clearance from the police personnel that this patient is donating. These are their relatives. This is their consent. So now we are proceeding for harvesting surgery. The police has to accept this, and they have to give a written signature on our this intimation form that cleared for harvesting. Only after completing this, we can proceed for transplantation. So organ allocation, and usually the first 2 seniority patients in each blood group in the hospital will be kept ready. And according to the seniority, first 2 patients will be called off, and based on blood group and cross match will be done. Suppose if the first person senior patient is cross match is negative, then they will be allocated. So post harvesting, organ retrieval authorization form. This form we have to fill it up and we have to send it to the transplant, and we have to inform the postmortem officer. At present, we can inform the forensic medicine of the nearby government medical college, and they can come here and do the postmortem in the harvesting hospital, and they can give the postmortem report to the patient and hand over the donor body of the donor to the family with due respect. So these the main barriers in transplant is need and supply mismatch is there. Lack of motivation of patients and doctors are there. Lack of awareness about organ donation is there, and difficulty in managing a brain dead donor and financial expenses for managing a brain dead donor. So these are the problems. And we can, I think, as because of this forum is very much active, we can avoid this lack of motivation in patient and donors can be overcome. So these are the donor difficulties. Recently, one patient was shifted to us with brainstem death suspicion, and that patient has undergone the investigations for 24 hours, and And then that patient is the Selva Kumar, and this is the patient with families willing for donation, and in-house kidney allocation was declined. We have declined the kidney in view of diffuse mottled appearance. So not every time you can succeed in donation after you receive a brainstem death patient. And what is the reason? This is how the kidneys were looking like. See, the kidneys are very dark red in color. So this kidney will not work even if we put it inside the patient. So we want a white colored kidney. So a well perfused kidney will perfusion will remove all the blood from inside the kidneys, and then the kidneys will be looking like white color at the time of harvesting and implantation. So, many times, but recently one kidney we received from one liver we received from Erode Medical College. We have to thank the coordinator and the team in Erode Medical College. They are doing an extremely good work, and we will see the transplanted patient. And this is what we actually for the Women's Day that was conducted before 10 days, we have identified the women kidney donors. So we felicitated the women kidney donors in our hospital in the presence of Dr. C.N. Raja, and then that was released in the press too. Because most of the times only the females are coming forward for donation, but we are not seeing the male counterparts for donation. And the number of comparisons will be 80% will be female donors for their husbands, and only 20% of the males will be donating for to the kidneys to the wives. So we have to overcome that too. And this is the press release, and that happened in our hospital. We did a liver transplant, and for this person before some 10 days. And then to be specific, and Dr. Rajesh sir was telling that the local IMA office bearers should visit the hospital at the time of handover. This happened in our hospital. Me being the IMA president, we have conducted we have assembled all our staffs of our hospital at the time of handover of the body to the patient. We just spent some 150 rupees for that garland, and we have to make all the staffs to gather at the time of this donation, and then we have to pay 1 minute silence, and we have to honor that donor and the family at the time of handing over of the body, because this is one thing that they do with selfless motive, and we have to be constantly in touch with the attenders of the family, and then we have to make sure that they are going home full-heartedly, because this is a one selfless thing that every person does, and we usually release this in the press too on the next day. So the pathway is early identification and clarification of brainstem death as a protocol in ICU, aggressive management of the brain death, early intimation to transplant team, effective coordination, creating awareness about organ donation among public and ourselves. On an average, if there is a cadaveric transplant, usually the transplant coordinators' night sleep will be gone for at least 2 days. And the transplant coordinators play a major role in completing a successful cadaveric donation. So this is when I was thrown in as IMA president in Erode, and thank you for all the office bearers of IMA for giving me this opportunity. Thank you.
Thank you, Saravanan sir, for giving a lecture. You stay on once Dr. Ramalingam sir completes his lecture. Then we will have the panel discussion with the panelists. Now I welcome Dr. Ramalingam sir. Dr. Ramalingam sir is the one of the most senior neurologist in Coimbatore. He is practicing in Hindustan Hospital near Lakshmi Mills. and he is going to give a talk on kidney donation, the urologist role. Dr. Ramalingam sir has got an innovative ideas, and he has done a lot of collaborations with the IIT, and also done a lot of studies with the Korean team, and he has come out with a lot of things. And he will be telling a lot about the kidney donation, the urologist role. Welcome you, sir.
Good afternoon, Coordinator Dr. Rajesh and Tamil Nadu State IMA office bearers. And thank you, Saravanan, for giving a good overview of the nephrologist and the urologist role also you partly told. So my job is to give the complex scenarios so that you can sort it out. So hope Dr. Balakrishnan is also there for the discussion. And this is the team which is the panel. So half of the information is already provided. Either it's donation can be from the living or deceased. And in a patient without any comorbidity, donor nephrectomy is going to be a very straightforward, both evaluation and surgery. These are the tests that are done routinely. Very easy. Once the patient comes in, you just check with an ultrasound whether both kidneys are there, and then do an isotope scan whether both are equally functioning or which is better or not, and then do a CT renal angiogram to know the anatomy. I'll just brush up very few slides so that it will re-emphasize of what Dr. Saravanan told in a much more pictorial way. And then the HLA and cross-match, and then go ahead with the counseling. Video counseling is very essential. You document everything so that there is a problem in the future who claims to be relative, found to be unrelated, and then at least you have the video recording. Though I have completed more than 1,000 transplants, in the last 200 or so, we used to take video conferencing counseling because we don't know which patient is going to give problem. So this is our recent change. And coming to the little bit of technical aspect, the standard of care today is laparoscopic donor nephrectomy. Most of the hospitals, they don't do open surgery because with a kind heart and mind, the donor is giving the kidney, so we should give the minimum morbidity to him. So laparoscopic donor is a standard of care these days. Through a small phalangeal incision, we remove the kidney, and this is how a perfect laparoscopic donor nephrectomy can be done. And the next day, patient is fit to go up and can be discharged in 40 to 48 hours. That's a small incision just below the umbilicus, and that's all. So then, the perfusion, most of the time, the nephrologists don't turn up into the theater. So we ourselves do the perfusion, and this is how we do the kidney transplant in the iliac fossa. If it is already operated case, we do the second transplant on the left side, and then we select the site depending upon the Doppler study of the extra-iliac artery and vein and intra-iliac artery. So whichever is normal caliber, without athyroma, without calcification, that particular site we select. We are not very keen that it should be done only on the right side. You can see the arterial anastomosis, that is the vein, and that's the ureter, that's the bladder. So now we come to the interesting aspect. What Dr. Saravanan told is all about the donor without comorbidity. But if we have a matching donor, like mother to son or daughter, where we don't have any other matching donor, if there are some small problem like obesity, small stone in the kidney, or cyst, or angiomyolipoma, then what do we do? These days, these are all called extended acceptance of the donors. We discussed this in a national forum. I was one of the faculty to discuss about the marginal donors. And we have laid the guidelines for the Urology Society of India. So I was coordinating and laid down all the USA guidelines for marginal donors. For example, here you have been used for the donor. I took the crossed kidney. Then the technical difficulty is the vessels will come from a different level, and then the ureter will cross to the opposite side. So it will be challenging. So I was presenting this in the National Transplant Coordination Committee in Delhi. So this is possible. This is going for publication. So next one, if you have a stone like this, do you take up these cases? Provided the other kidney is normal, these two small stones can be managed in the future. So this we take up as a marginal donor, and we do the harvest the right kidney, leaving the normal kidney for the patient. That's I want to emphasize again and again. Small stones in the transplant kidney can be managed easily with a flexible ureteroscopy. So we don't have to reject this donor if it is a good match and relative. This is the flexible ureteroscopy. You can see the stone inside. In the post-transplant scenario, this stone was removed by a flexible ureteroscopy. Sometimes we have a small cyst in the kidney. So do we accept this? Yes, if it is a good match and relative, we accept this and we do the bench surgery and then remove the cyst, and then we can get a hemostasis like this and then do the transplant. This is a case where there was a small angiomyolipoma. You can see here, low density mass. So we take this as a prospective donor, and then you can see here the angiomyolipoma has been removed, and here you can see another small tumor in the kidney. We go to the extent, if a tumor is less than 4 centimeters, we take this as a graft, and then we do the bench surgery, and then remove the tumor with a 1 mm margin, and then keep this for the recipient, and then we follow it up. So only thing is we need to follow it up. Rarely you can have a very obese patient. So generally, if the patient is above 70 years and obese, and if the BMI is more than 35, we don't accept. But because of the paucity of the donors, and if this is the only matching donor, then we have to accept a little bit of risk and then go ahead. So it is still possible to do a laparoscopic donor nephrectomy in this obese patient. We have to take care about the post-operative pulmonary consultation, and DVT embolism. Pulmonary embolism can happen in about 2 to 3%. So we have to be very watchful, do a good chest physio, and then we even start heparin 24 hours after donor nephrectomy, especially obese patients. And then maybe a day or two, we will keep the patient under observation and then discharge. Normally in a lab donor, we discharge the patient on 48 hours. But in these patients, obese patients, we can keep them for 3 days or so. Coming to the cadaver kidney harvest, this was the first cadaver kidney. We did it in 94. I think Rajesh was also there in KG Hospital, the first in the South India and second in the whole India. Those days, there were no organ sharing committee or recommendation or protocols. So I have to remove both the kidneys and then do 2 transplants. So this is a long midline incision. You remove both the kidneys with aortic cuff and IVC cuff, and then do transplant in 2 patients. So we start the surgery in the night, say around 7 o'clock, until morning. We have to do the harvest, we have to do 2 transplants, So first 12 cases in South was done by our team in KG Hospital. And it was, sometime when you have a pediatric kidney cadaver, we take both the kidneys and then we transplant both the kidneys in the iliac fossa or the prospective recipient. That's the IVC. We take the IVC cup, we take the aortic cup, and these days we have to give one kidney to the other institution, and that's how the cadaveric kidney transplant looks like. That's the picture. So even if the patient is beyond 70 years, if the isotope scan says okay, we may even consider this one. So at this stage, can I put some questions to the panel, Rajesh? Dr. Rajesh?
Yes, sir. You can go ahead, sir.
So I just covered the surgical aspect of the live and cadaveric transplant, and let me have a question to Dr. Senthil, who is here, one of the panelists. If you find, Dr. Senthil, if you get a patient of 70 years and above and obese, and will you take up this, consider for donation?
Sir, as such, there is this is a situation where the patient has not had any other donors, probably. That is what you are trying to say. So which means he's the one, when he is the only available donor, if his general condition is okay, he's not diabetic, he's not hypertensive, then we can consider this is called as the extended criteria donors or marginal donors. So we have to make sure that his kidneys are okay. So he should not be put to harm by removing one of his kidneys. So we have to check his renal function. We have to make sure that the kidney is suitable for transplant, which means surgically it should be an easy procedure. It should have only one. Preferably the artery should be single, or even if it's double, it should not be very difficult procedure-wise. Thirdly, he should not have any proteinuria, and also the renal function, we can do it by means of isotope renogram, and that should be favorable in terms of doing a transplant. This person is obese, which means he may have surgical complications. So if his BMI is less than 35, then we can take him up as long as the family is willing and the patient is also willing.
Thank you. That answers the question.
Sorry, as per the norms of the transplant and also the NOTA, they are telling that there is a age limit is no bar. Previously, there was a age bar up to 65 years, sir. Now is that they have removed that age bar actually, and they have given an announcement like that. And also the area wise also they have told that there is no region wise state, from one state to other state, you can transplant like that. So these are all the two modifications that have come in the NOTA also, sir. So that is a nice thing. And you have also brought about the person with 73 years. Very nice discussion, sir. Thank you, sir.
Dr. Sendil, if you have a child brain dead, what are the surgical techniques which think it is different from the conventional transplant? There's a 9-year-old girl who met with an accident and was brain dead, and we had the opportunity to do a transplant. So what are the concerns, and what are the points of technical difference you want to highlight?
In a very young girl, the kidney is smaller, which means the GFR will be smaller. So maybe if there is a matched donor, a matched recipient who is the same age, then it is fine. Then it is no problem. If it is matching properly, then we can always give it. But if you don't have a matched donor, matched recipient, and you're going to transplant this kidney into the adult, then you have to take both the kidneys together along with the aorta and IVC, and then you can transplant it into the recipient. And the ureter also might be smaller, so when they combine together, the total GFR might be reasonably okay for the recipient.
Now, what will you do for the? There will be two ureters. If you keep both the kidneys in an adult, suppose you have 50 years with a good build, one kidney may not be sufficient, as you said. So, what will you do for the ureters? You will have two ureters. What will you do?
Yeah, both can be implanted into the bladder separately, or you can anastomose one ureter to the other, and then both can be the single ureter can be anastomosed into the bladder.
Okay, what vessel will you anastomose to what?
So because it's a larger one, we'll have to put it into the common iliac artery. It might be preferable to anastomose the into the common iliac artery.
Okay. Do you anastomose to IVC and aorta sometime?
It is possible. We can, if the girl is a well-built girl and it's bigger kidneys, and if you think that the vessels are too big and it will cause steal of the blood flow into the kidney, then we may have to use the aorta or IVC.
So, because we are using the IVC and aorta into the external iliac artery, that we steal, as Sendil said. And second thing is the space also is a problem to accommodate both the kidneys. So, especially when the prospective recipient has a atheromatous external iliac artery or internal iliac artery, then we have to put it into the IVC and aorta. Thank you, Sendil, for the prompt answer. Suppose we have donor kidney with ectopic fused kidney. Then either do you reject this patient, or do you still consider ectopic kidney? Do you accept?
Ectopic kidney,
what are the problems?
The main problem is, as you mentioned in the slide, vascular anomaly is a problem. Generally, they may have multiple arteries. And if the artery is of a reasonable size, which can be anastomosed, then it is fine. But if the artery is very small, we cannot anastomose all the tiny vessels, which may cause loss of function in the kidney, part of the kidney. So if we are losing more than 1/3 of the function, then if it is having multiple vessels which are small, then we may not be able to use that type of kidney. But otherwise, if there is a relatively bigger sized vessels, we can always do even double or triple anastomosis into the external iliac artery, so it can be taken up. Ectopic kidney is, as such, is not a contraindication for donor.
Yeah, just want to highlight that the artery and vein may be coming from the common iliac, sometimes even from the external iliac in a pelvic kidney. So the ureter will be very short, wherein you have to use the flap from the bladder called Boari flap. Or you may have to anastomose the UPJ to the native ureter of the recipient. So that's a technical point we want to highlight. Thank you, Sendil, for highlighting. And this is how the perfusion and everything has been highlighted by Dr. Saravanan. Suppose you find, and this is the Rotary Award given to the team, our team in '96, for doing the cadaver transplant, second in the country and first in South India. And now that we have come to a reasonable technical knowledge, so we want to highlight something about post-transplant scenarios. If a donor who has had a donation comes to a family physician, what are all the things one has to consider or be aware is that the NSAID should be avoided as much as possible. If they are not coming regularly to the follow-up to the transplant team who has done the surgery, it's okay. But at least the family physician can do a regular checkup of the BP and then a renal function test. Because for some time there will be compensatory hypertrophy of the other kidney, but afterwards they can progress to little deterioration in the renal function. So they have to be followed up lifelong. So whoever is seeing the patient who has donated the kidney should be counseled that they have to be followed up. And especially microalbuminuria has to be looked at. Very simple test can be done by anybody, any family physician need not go to the urologist or nephrologist all the time, but it is better in the same setup where he has had the surgery, can be followed up. So again, when a post-transplant patient goes to a periphery for fever, we want to highlight that please don't do the BP checkup in the hand where he's having the AV fistula. Sometimes it can rupture. Then the minimum investigation one has to do are urine for pus cells. Within few minutes, you can find out wherein patient may not have high-grade fever, even in endotoxemia. So one has to look at that and send the urine for culture before starting the antibiotic. And total count can give a clue that whether active infection is there or not. Again, avoid aminoglycosides unless that is the only suitable antibiotic and NSAID. Just want to highlight. And again, coming to scenario, pre-transplant, ESRD patient waiting for a transplant. I would like to pose this question to Dr. Balakrishnan. Dr. Balakrishnan, are you logged on? Dr. Balakrishnan? Okay, if he's not there, let me put this to Saravanan. Dr. Saravanan? Hello? So some interesting scenarios I want to highlight. Not there. Interesting to give some clinical scenarios and then
Sir, 1 minute, sir, he is coming.
And is he coming?
Sir, he is coming, sir. 1 minute.
Okay, then I will go for other scenarios. Okay. This is actually adult polycystic kidney bilateral. It can end up in renal failure and in some patients even ESRD. Patient will have hypertension, pain, sometimes due to bleeding, sometimes due to infection. So that I want to highlight. Size. The size is, it will be anywhere from 10 centimeter to 25. We have even operated on 30 centimeter sized polycystic kidneys before transplant, just before transplant, post-transplant. All these three scenarios we have operated. Let me see what the nephrologist has to comment upon. Dr. Saravanan.
That's wrong, sir.
This is a case of bilateral APDKD in ESRD on maintenance dialysis. And it's a huge bilateral cyst. So what is your comment about pre-transplant or during transplant or post-transplant bilateral nephrectomy? We have done all the three occasions. What is your suggestion?
Sir, ideally the patient has to, because the size of the kidneys is more than 20 centimeters, it seems. So there will be space constraint for putting in the third kidney in the presence of this much bulkier native kidney.
Correct.
And some cysts are having hemorrhagic transformation also that can be infection or something else can be going on there. Ideally, this patient has to undergo bilateral nephrectomy before transplant, and then the patient has to recover from that operation, and then the patient has to proceed with the transplantation. If that is not possible, then we can have to take up for nephrectomy on the table before implanting the third kidney on one side, possibly if there is the other side kidneys are ruled out of any infections or any malignancies. So this will be the picture for this patient.
Yeah, agree with you. If it is a painful kidney, then that has to be removed. If it is asymptomatic, what generally we do is we remove the right kidney, little extended incision, and then do the transplant on the right iliac fossa. And we don't want to leave the patient anephric, so that's why we want to leave the left kidney for a while. Once the transplant kidney picks up, then we can go ahead and do the post-transplant nephrectomy on the other side. Sometimes even by laparoscopy, we can puncture the cyst and then remove through a small incision. So that is the. So only thing is very large kidneys with sometimes hematoma or infection, fever. Then we have to do pre-transplant to avoid any sepsis in the post-transplant period. Saravana, if you find a patient with neurogenic bladder, very small capacity bladder, what we describe as a bad bladder, then what do you do?
The
So what are the workup you will other than the conventional MCU and
we don't want to put in a third kidney with reflexor ideally. So if you are going to implant a third kidney with a reflexing bladder, then high pressure, small capacity bladder, it is a problem for the future outcome. Patient will be developing induced recurrent urinary tract infection. Already patient is sickness. There will be a lot of urinary tract infections in the post-transplant. So definitely this bladder needs to be reconstructed, and that bladder augmentation procedure has to be necessarily undertaken before putting in the third kidney. And I think even if we anastomose the ureter with a non-reflexing procedure, if it is a small capacity bladder with high pressure bladder, then definitely that anastomosis may leak that can develop further reflux in future. It's reconstruction.
So what we do is we do a urodynamic study, MCU, and if it is a poor compliance bladder, we do the laparoscopic augmentation cystoplasty using the terminal ileum to make the bladder more compliant, and then do the transplant anytime 2 months later. So that is, it's very important you do a urodynamic study and then do the augmentation cystoplasty. I will show the image at some time. And then coming to the post-transplant scenario, Dr. Balakrishnan, if you are there, you can answer this one.
So Dr.
The patient
Balakrishnan is
develops a
having a
stone in
problem
the
with
transplanted kidney. I see. Then Saravanan can answer. If you have a stone in the post-transplant kidney, you can see it here. So what are the special precautions you will do and how will you manage this stone? My sister on the papa. Only on the white on the phone.
Hello. Yeah.
Yes, sir.
Intrarenal stone, even if it is in the post-transplant scenario, if it is more than 5 millimeter, if it is going to be producing a source of infection, that needs to be taken care of with possibly an RARS or lithotripsy, and that stone has to be broken. And as far as possible, there should not be any stone burden after the procedure, sir, to prevent a further urinary tract infection as the patient is immunosuppressed.
Dr. Sendil, what is the technical difference or challenges you will face if you find a stone in the post-transplant kidney?
First of all, we want the urine to be sterile. Secondly, the ureter is actually not in the normal orthotopic position. It's in the different position. So to cannulate the ureter, it might not be straightforward, which means we may have to use a flexible in the first place itself to identify the ureteric orifice, place a guide wire, and then go ahead. The other way we can do it is actually do it because it's very superficial and quite accessible from the skin. you can always place an antigrade guide wire and then puncture the kidney and pass an antigrade guide wire and then pass the ureteroscope from below and take the stone. It's very good also do a percutaneous nephrolithotomy.
So if you find the stone like this in the just above the hiatus and significant hydronephrosis and recurrent UTI, so what would you suggest? Is it a PCNL or a RIRS or a open surgery, or will you reimplant? Is there a stricture? So what are your suggestions, Dr. Senthil?
There are two things that come to our mind. One is whether this stone by itself is causing the obstruction, causing hydronephrosis, or whether there is a stricture at the anastomotic site or just above the anastomotic site. In which case, we'll have to identify whether there is any obstruction. So here I can see this picture. They have done an epicostogram, and that shows there is quite a significant obstruction at the level of the stone. So ideally, what we can do is puncture the kidney from above and then flexible ureteroscope come down, and then we can do a lithotripsy of the stone, and then we can subsequently do we can put a stent, and before removing the stent, we can do a study, a nephrostogram, and make sure there is no stricture, and then go.
Okay. So if you are not able to look at the ureter in the normal location, so passing a guide wire in this scenario will be easy, or it's a challenge?
It will be a challenge. Only after breaking that stone will be able to pass it.
Okay.
Sir, Dr. Balakrishnan has joined, sir. You can ask some questions for him also.
Yeah. Good afternoon, Dr. Balakrishnan.
Good afternoon, sir.
Welcome. We were discussing some scenarios like APD at the time of transplant, whether you will remove it at the time or after transplant. So what is your view? Large kidneys, 25 centimeters, asymptomatic. So would you recommend the pre-transplant nephrectomy or at the time of transplantation?
If there is a space constraint, we have to remove the left kidney before transplant and the right kidney during transplant before implantation. So if there is if we can place the kidney, there is not much of difficulty in placing the kidney, we can just do that. No need for nephrectomy.
This is about 25 centimeters. The abdomen is full.
Yeah, in that case, we have to remove it.
Okay, this is one case where very small capacity bladder with ESRD awaiting transplant, just 50 ml capacity bladder. So how will you evaluate? ESRD and dialysis, very small capacity, 50 cc bladder.
We will refer to the urologist.
Okay, we do the cystogram and urodynamic, and then see if it's a poor compliance. Then we do the laparoscopic or even open augmentation ileocystoplasty to improve the compliance. Otherwise, the grafted kidney is going to lose the function. Yes. So I will show the image sometime later. And we discussed, Saravanan discussed this about, and Senthil discussed about this post-transplant stone. And yes. I have another scenario. So you want to say any comments? We suggest PCNL. So do you recommend any other method?
Sir, I joined only now, so I don't know what was the discussion. Subsequent things I'll...
No, renal stone post-transplant, about 2 centimeters.
Okay. Sir, this is again a urological problem. We will refer to the urologist, and as per this thing, we will go by that.
Okay, anyway, you will be following the patient, no? This is another patient, post-transplant 5 years. He is about 50 years, and his kidney is working okay, and he had 2 episodes of acute urinary retention, CC volume.
Okay.
So went in for retention twice, catheterized, alpha block is given. So months together he has been 1 month. So we have been putting on alpha blocker, now and then catheterized. And so what are the special precautions or any suggestions from your side? Large prostate.
Sir, we have
diabetic,
to...
hypertensive, creatinine is about 1.2, 50 years gentleman.
Sir, if there is significant obstruction and already has gone in for acute retention twice, after eradicating the infection, probably I think we should go for a TURP.
Yeah. Only thing, point I want to highlight is sometimes the people's diabetes is very, very poorly controlled. Diabetic cystopathy may be a component.
Yeah.
If it is a painless retention, it is advisable to do the urodynamic study. And if it is only a diabetic cystopathy, he may not benefit by TURP. We advise self-independent catheterization. If it is a high pressure system in the urodynamic, then we do the TURP. So urodynamic has got a role, especially in a diabetic and elderly. So this one I posted to Saravanan. Ureteric stone post-transplant, will you do a ureteroscopy or will you do PCNL? It's in the juxtahiatal level. So which way you go, Dr. Balakrishnan? From below upwards or above downwards?
Sir, above downwards, it's technically difficult. I think above the PCNL will be a better option.
Yes. I mean, below upwards is difficult because the ureter will be in the anterior wall of the bladder. To even pass a guide wire in an acutely obstructed ureteric stone, even guide wire may not go. So here you can see that the guide wire was not going, coiling around. So we had to do a PCNL. So that is a dilated system. A PCNL is much more easy. That's the... So only problem is PCNL. You see on the just in front of the graft kidney, the bowel may come. So one has to be very, very careful in doing an ultrasound and fluoroscopy both to puncture the collecting system exactly where it needs to be done. I have a question to Dr. Senthil. This is the only matching prospective donor. You have a small SOS, small maybe RCC, maybe oncocytoma, maybe AML, only matching donor, mother to son. Will you accept this as a donor?
There are a few things that come to our mind. First of all, we have not confirmed that it is a malignancy. Second thing is whether the other kidney, which is looking better, is good for the patient. There's an ethical dilemma there, whether to leave the kidney with the tumor for the donor or take the kidney out and then do a bench surgery. The point that comes to our mind is if it's a very small tumor, less than 4 centimeters, the overall survival rate is around 90 to 95% if we have done a partial nephrectomy. So keeping that in mind, we can assume that even if we transplant this kidney into the region, they are going to survive about 5 to 6 years. So what we could do is to, at the time of transplant, if there is no other option and if that is the only option, and if the patient has been fully explained and if they are willing and if the attender is willing, then we can go for it. And at the time of surgery, we can remove after removing the kidney during donor nephrectomy, that part of the tumor can be removed and we can confirm by frozen section that there is nothing left behind and it is it can be done, keeping in all these points in consideration.
Okay, that's the extended criteria for organ donation. So we had a national transplant meeting wherein we discussed all the extended criteria, marginal donors, and it was discussed. And it is such a slow growing CA prostate and renal tumors. Depending upon the histology, it's a very slow growing. If you have even 1 millimeter margin, it is almost taken as cured. So we have done a partial nephrectomy on the situation and then transplanted. So that is the point I wanted to highlight. So thank you, Sendil, that we can take up that patient for organ donation. And now I just wanted to share another picture. How we do the I have a question to Dr. Balakrishnan.
Yes, sir.
Recently, there was news that xenotransplant has been attempted.
Yeah.
So what do you foresee? We have so much shortage of live donors, cadaver donors, lakhs and lakhs of people are waiting. So will that work out, or it will take a long time to do that? 1 minute, Balakrishnan. I just got the image I wanted. This is a small capacity bladder I wanted to show, and so this is how we do the augmentation cystoplasty. Okay, this is the small capacity bladder on the distal aspect. This is the small bowel. We do the laparoscopic augmentation cystoplasty and then wait for 2 months, repeat the urodynamic study. And then if it is a complaint bladder, then we go ahead with the transplant. If I'm back to... So the question to Dr. Balakrishnan about the xenotransplant. Balakrishnan?
Yes, sir. Sir, it's going to be
So
a boon to the
any thoughts?
Yeah, definitely it's going to be a boon to the waiting patients, many of them, and the shortage, everything will be overcome. It is another milestone in the transplant history, and it has come to a great extent. And now that it's been transplanted to a black man, and he seems to be doing well, but needs to be followed. And once that's acceptable with not major risks and rejections and infections, definitely it will have a role in transplantation.
Will the antibiotic protocol be different with the human beings because the pig will have some different organism, no?
Sorry, as of
may
now,
be different.
Yeah, as of now, there is no clear-cut idea about all those things. What all the routine prophylaxis has been given is given to this patient also. So we have to foresee some other infections or something, and based on that, we have to cover those organisms. These are all in a very primitive stage. We have to foresee this thing, but for this patient, they have given only the routine prophylaxis, what's been given now, nothing new other than that.
And the immunosuppression protocol?
Immunosuppression is same. Induction is same. The maintenance immunosuppression is same. Only thing we have to watch for, this is a very early stage. We don't know whether any zoonotic infections we are going to come across, or whether there will be any severe rejection episodes, all those things. So this is a first step forward in xenotransplantation. Hope everything will go well and this will come into practice.
Excellent. And then the last question to you is, some people who are on hemodialysis, averse to hemodialysis, they don't want CAPD, there is no matching donor for the thing. You have any idea about this wearable artificial kidney? So what will happen in the future? Will this come to day-to-day practice, or will be only in the research lab?
Sir, this has been there for quite some time, and this is coming on and off in the news. But I don't think so that this has been very acceptable or comparable to the conventional hemodialysis. So it has not come into practice. In that case, this is not practicable. I think that's the reason it has not come into vogue.
So will it come into work in another 5-10 years, or some modification in the
I don't know.
horizon pipeline?
I don't know, sir. The researchers have to address the problems, rectify all those things, then it may come.
Make it smaller.
So do you call this as ambulatory peritoneal dialysis, CAPD?
No, no, this is not ambulatory peritoneal dialysis. This is a wearable kidney. They call it
This
as
is variable kidney, sir. This is variable kidney.
Okay. Thank you, sir. Babu, sir, thank you.
Small tube attached to the abdominal wall where the patient can infuse the dialysate, and then it will be indwelling for about 3-4 hours in the morning and 4 hours in the night. And the peritoneum acts as a filtration. So that is the thing that is a media between the dialysis and these things. So that's all the question, and from our side, Dr. Balakrishnan, you want to highlight anything regarding the future prospects, immunosuppression protocols? Is it going to change? In the last 10 years, we had seen a lot of change in the immunosuppression protocol. I had visited the Institute of Kidney Disease, Ahmedabad. They seem to have a very low dose of immunosuppression protocol. So what is your suggestion? I think they have some publications as well. And you see the other extreme here.
Yes.
So 3-4 immunosuppressants and then antibiotic left and right. And so what is your suggestion about the immunosuppression and antibiotic?
So the
In
ideal...
Vellore, you and I were in Vellore, no? At that time,
Yes,
we
sir.
used to give only 80 milligram gentamicin, 1 dose. Am I right?
Yeah,
For the transplant
gentamicin.
day, only 1 dose, and then we put gentamicin in the bladder wash solution. That's all.
Yeah, yeah.
No antibiotic.
Yeah. So the thing is, mainly the achievement of tolerance for the graft is the aim of everyone. So now there are certain research aspects in all those things which is going forward. And if there is a tolerance, if tolerance is able to be achieved, definitely it will help in minimizing the immunosuppression and the complications. I think. But still it is not very successful. There are research going on and certain milestones are achieved but not come into practice. But the tolerance is the only thing which can be very helpful for the patient in achieving a tolerance to the graft and minimization of immunosuppression and its added the complications.
And about the antibiotic prophylaxis, patient's culture is sterile, blood culture negative. So how long you want to give antibiotic during and post-transplant?
Sir, ideally, the thing is to see that the patient will not get any infection. So in the immediate post-operative period, we put him on a Foley's tube and IV lines and all those things. And especially even we to regularly cover them with say ceftriaxone, sulbactam for a week. But generally, we don't come across any major problems or major infections. But to avoid this, we are also practicing giving antibiotics for the first week.
Sir, excuse me, sir.
Thank you very much.
Sir, there are 2 coordinators, sir. There are 2 coordinators, sir. Transplant coordinators.
That's what I am coming to, Rajesh.
Devi Subramaniam and Mohammed Sahir, sir.
Rajesh, I would like to ask the Mohammed Shahib about the responsibility of the coordinator. So just highlight on the coordination.
Mohammed Sahir. Hello, Mohammed Sahir.
If he is not there, Dr. Devi Subramaniam can answer that one.
Can you ask me once again, sir? What is?
Yeah.
Sir, question repeat பண்ணுங்க sir.
Oh, okay. I will unmute. David Subramaniam, can you brief what are your primary responsibilities so that there are more than 300 people are watching, so they will know about the transplant coordinator, designated one, which every hospital doing transplant should have one, and what are your primary responsibilities?
And all everyone here. I am Devi from Kovai Medical Center and Hospital. I am working as a transplant coordinator last 8 years. Disease donor transplant coordinator role related, sir, or living donor, living transplantation related, sir?
Disease donor.
Disease donor. Yes, sir. After the ICU consulting doctor, invite the transplant coordinator. We have a back role of the disease donor transplantation coordination. In the same time, we are coordinating with transplant and the donor family at the same time of the recipient family and the in-house donor hospital. We have a short time to the everything in the process of the coordination. We have to call a recipient in the waiting list in the transplant who active in the listed in our hospital, and we have to send the list to the transplant. Every month we have updated the active patient recipients list. After the donor, we have the donor checklist in our transplant website. We have to collect the clinical details with doctor support, and we have to make transplant time, and the same time we have to cross matching process. We have to collect the sample, and other hospital who all are coming to the in-house hospital. If they are not coming, we have to send the sample to the cross matching center, and we have to inform the police and forensic officer also, and the other hospital who are all in distance. We have to make arrange and support to them. So many process in this coordination in our hospital, and everyone known about this. We are the major role, our back support to the doctors and hospital and transplant and any other things in the disease donor transplant program. Till the end of the donor handover to the donor family. After the donor donation, we have to follow up with this them family member they are missing. So if any further follow up also, we have to following. Thank you, sir. If anything want to ask.
Now, will you be involving a psychiatrist at some point of time for counseling, or you do the counseling?
Maximum we will support to the counseling, sir. They are depending the situation. We have to consult and primary consultant, and me also do the counseling, sir.
So, Rajesh, Saravanan, Balakrishnan, any questions you want to pose for any one of the panel? Welcome.
Hi, sir. This is Shahid, sir, from Jammu Hospital.
Yes, sir.
Yeah, this is Shahid, sir, from Jammu Hospital, sir.
I just wanted you to briefly tell about the primary responsibilities and any problems you had faced so that everyone can learn from your experience. And the basic responsibilities, Mrs. Devi Subramaniam just pointed out, but in your case, more than a decade, did you face any difficulties? And you can tell us so that how we can coordinate.
Hello, sir. Do you hear me,
How
sir?
do the family of the deceased take up, and what problems you have faced?
No, you tell your experience about how you will deal a person with a live donor transplant and also the deceased donor transplant. Both your experience you can discuss. That's what sir wants to know.
Hello, do you hear me, sir?
Yeah, we are able to hear.
Yeah, actually, in my experience, I have a bitter experience in this donor in donations, organ donation with the police department, sir. Because in MLC, we have to inform with the police department to do the legal issues. So that time I really faced a lot of bitter experience from the police department, sir, because they don't know even what is the brain death and what is the death actually. Then at last we got a support from the postmortem department. Then they convey the difference between the brain death and the normal death. Then after that, only the department persons that helped me to do the organ donation, sir. Sir?
So regarding the live donor, what is your experience? You tell.
In live donor, we don't much have a. I didn't face anything in a live donor sites. Everything is smooth because nowadays, in recently the transplant they changes a lot of changes in forms. In form 1, they give clearly for a close relative. They mentioning like for to the siblings and for grandfather, grandmother, father to son, daughter to son. Then form 2 for spouses and form 3 for you are unrelated, sir. So everything is getting smooth. So I'm not facing anything in a live donor, sir. Actually, the counseling also so easy than the cadaveric donors.
So I welcome Dr. Kanagajala Kumar sir for joining the program as our organ donation committee member. Sir, do you want to ask any questions to the panel, sir? Kanagajala Kumar sir.
Am I audible?
Yes, sir, audible, sir.
It was a very nice CME program. Lot of participants, more than 300 participants today. It is really very nice, and they were able to clear all the doubts. I don't have any questions.
Sir,
can I go in for note of thanks, or you have any?
No. We will have discussion.
Okay,
Sir,
okay. I know Dr. Ramalingam sir, because I was fortunate to work with him when I was doing MS. He was doing MCH at MMC. He used to give a lot of chances and he used to teach very basic things. I cannot forget those days. So I was fortunate to work with Dr. Ramalingam sir.
Hello, can I get? Nice
Hello,
seeing
sir.
you.
Nice, sir.
Okay. Pleasant memories those days. Taking class for the PGs was a very, very enjoyable moment.
Yes, sir. Actually, Dr. Ramalingam sir did DNP at CMC Vellore, and later on he came to MMC for MCH. In fact, that was the first PCNL case you are witnessing. In fact, the chiefs, everybody were getting the guidance of Ramalingam sir. That was the credit to Dr. Ramalingam sir.
Thank you. Thank you. Thank you. Dr. Saravanan, you have any questions to any of the panel?
Devi, while doing organ donation coordination, what is your actual job? How you do your job in the live donor transplant and also the deceased donor transplant? What is your role? What are all the things you are supposed to coordinate?
Yes, sir.
You tell what you will do.
Yeah, I'm doing after the clinical evaluation, sir. I'm getting the approval from the government.
Doctor is saying it is a brain dead patient. Now,
Okay.
now while talking to the attenders, you will be there and you will be doing a counseling and for mobilization. Like that, I am asking you. Your experience in any one of the cases, how you dealt the patients. That's what.
Maximum the primary consultants in ICU, they will counseling all the, our role start from the after the counseling in our hospital, sir. I'm doing.
Yes, you can tell.
Yes, sir. After the primary consultant and ICU consultant counseling the donor donation, after the donation, all the donation details, counseling to the donor family, and then after the ICU consultant and primary consultant counseling the donor family, after that only my role is started in our hospital. Regarding the time of donation timing and transplant role and in our in-house hospital related coordination and recipient coordination and police information and regarding this forensic medicine office coordination up to the end of the every program, I am taking care of my role, sir.
So what are all the forms you need to fill up? And what are the things you are?
Yes, sir. Form 8 and Form 10, sir. The disease donor program. I 4 M-panel, 2 M-panel and the medical director and then the ICU consultant, 1 neurosurgeon and the medical director. We have to collect from the Form 8 from the checklist. We have to take the photos and send to the transplant and get the correction also. And Dr. Saravanan sir saw the police forms and everything, organ function form also we have to get the donor consent from the donor family in their own language. We have to submit all the documents related to the transplant. This is our role, major role, sir.
So once after the transplant, what is your role?
We have to go to the transplant ICU and see the patient recipient, how come with doctor, sending the organ utilization form and where to take from the organ. We have to send the donor maintenance charges also and counseling to the recipient how to take the advice from the doctor, medicine and tacrolimus test also we have to follow. We have whatever support patient need, we will guide the support, sir.
Madam, when was the last transplant was done from the brain dead patient in your institute recently?
Yeah, 2023 October in our hospital, sir. After that, we didn't any receive brain dead recipient. We have to counsel 2 patients, but not willing in our hospital.
It was only in October 2023. After that, no.
After yes, sir. 2023 October.
So what are the organs that were transplanted? Which were all the organs which were any idea about that?
Yeah, sir, sure. Heart, they are taken coming from the MGM and the PHG, but heart function is not good. That's why they are declining. Lung also declining. Both kidneys and liver we used and cornea, cornea, not skin, sir.
All these things used in KMCH?
No, sir. Only one from the KMCH, another one sent to the GKNM, sir.
Sir, Dr. Balakrishnan, sir.
Yes, Rajesh.
So how about your experience about the transplantations in the brain dead patients, sir?
Yeah.
Your experience. You do only the live transplant or disease transplant also you used to do?
We are doing both. Ours is not an organ retrieval center. We don't have facilities to retrieve. So we get kidneys for our patients registered only from the organ retrieval centers. That's called a share kidney. So once it's allocated to our patients, we get the donor blood for cross-match, and if the cross-match is negative, it is conveyed to the transplant. Then transplant will ask us to go ahead for the further this thing. We go to the donor hospital. There the organs are retrieved by the organ retrieval team, and we collect the kidney aseptically in a ice box, and it's transported to the recipient hospital where it is implanted. And already the patient is preserved, the bed, everything is prepared. Once the kidney reaches the hospital, it's immediately anastomosed, and the patient is shifted to the transplant ICU for further follow-up.
Regarding this registration, Bala sir, what is the real procedure? Because there are a lot of procedures. People are telling it can be done only through the hospitals and nephrologists. I'd like to know what is the real procedure of doing the registration.
Yeah, well, the thing is, it's a requisition letter that has to be given by the patient, which is to be forwarded to the transplant through the hospital, treating hospital. It is generally people who don't have any donor prospects in their family, and they should be at least on hemodialysis for more than 3 months. And these people, their application will be forwarded to the transplant, and there is a registration fee for that. I think it's
actually, what is the fee, sir, approximately?
I think it's a DD for 3,000 rupees to the government of Tamil Nadu. And before sending that, we have to also screen the patient for the cardiac clearance has to be obtained. The patient should be in a relatively stable health, and he should be acceptable for transplant. All those things to be screened, and we have to submit the application with all these other remarks and the patient's condition, everything. And once it's accepted, then they will be put in the wait list, and they will be allocated a number according to the seniority. And this keeps on moving. And once that particular patient comes in the list first, he will be allocated.
Actually, how to see the waiting list in the transplant, sir?
There is a website which is open to all, and even the patients also, they can see. And based on the group, it is divided into zones, and they can see their list in the in-house hospital. There's the waitlisted number in the in-house hospital, and also in the zone list also. There is a west zone, the east zone, north zone, and mainly 3 zones are there. And based on the zones, they can see their waiting list in the zone list also. For each group, O group, A, B, B, all the 4 groups.
So actually, for this organs, how much you need to pay when you are a recipient from the brain dead patients?
For the hospital, for the treating hospital, that is where the retrieval is done. For the kidneys, it's 25,000. It is for the donor maintenance. It is not a charge for the organ or something. It is the government has worked out for the cost for the donor maintenance. Once they have consented to donate,
you need to pay for maintenance is 25,000.
25,000. I don't know for the other organ. I don't know for the other organs. I think it's for the liver 50 and heart 50, something like that. I don't know, but it's more than the kidney.
Then regarding this organ donation transplant, sir,
one small
how about yes, sir, Saravanan, sir.
All 25,000, sir. Recently, even if the liver is taken by a hospital, one organ 25,000. Each kidney 25,000, and liver 25,000. If heart and lung is used, 25,000.
Each organ is 25,000.
25,000. The utilizing hospital will transfer to the donor management hospital.
Any maximum limit is there?
No, sir. Only this is the maximum. Nothing more than this is possible.
No, sir. For example, there are different organs now.
Sir, as per the legal standpoint, donor management hospital cannot claim more than 25,000 per organ to transplant or anyone else?
No, sir. What my question is, for example, if you take a heart 25, lungs 25, liver 25, then 2 kidneys 25.
That's
So
it, sir.
it automatically crosses 1.5 lakhs, no, sir. Any upper ceiling is there or not? That is my question. Anything you know about it?
Sir, this is the minimum and this is the maximum. So no, nothing more than this or less than this can be charged. So recently we had a liver donation that happened in our hospital. We have raised the bill to the utilizing hospital, that is Ramakrishna, and then they have transferred us 25,000. That's it. There is no more or no less. It is not like that anymore. Only heart, liver, lungs, kidneys was accepted to be the organs that can be paid for to the donor management hospital.
Sir, regarding this CM scheme, sir, whether the donation is covered in the scheme, CM scheme.
Sir,
how much they are giving?
Sir, Dr. Balakrishnan sir can tell first, sir.
Yeah, it's covered. We have to get an emergency approval for that. And it is same as for that's given for the live donor transplant.
How much is given, sir, actually?
Saravanan, you can add to whatever I have said.
Actually, sir, there is one package under CM scheme, and for transplantation, they don't bother about live related transplant or cadaveric transplant. They bother about transplant. That is one package. That is one package of transplant. They will give 2.3 lakhs first. This will be settled to the hospital after we submit the claim documents based on our documents that will be settled within 2 weeks to 4 weeks of the discharge of patient. And then rest 1.7 lakhs will be paid for post-transplant immunosuppression. And that is what we are usually giving for our patients for post-transplant follow-up. Doing a transplant alone is not going to be useful. And if they are not taking medicines as per our recommendations, their graft will fail and they will come back to dialysis. And entire transplant work will be gone for waste. So that is why our CM scheme is covering the post-transplant immunosuppression, and usual package rate after 1 year for post-transplant immunosuppression will be 12,000 a month, and that will cover the first 3 medicines that we give for transplant. Usually it is tacrolimus, mycophenolate, and steroids. And as I told before, the 2.3 lakhs, other 1.75 lakhs will be settled by the financial committee for the first 3 quarters. 25,000, 25,000, 25,000, 25,000. In that way, they will settle to a total of around 3.6 lakhs. It will come for the hospital, sir. But the rest 1.3 lakhs will be settled after 1 year. And there are a lot of delays in this. So many private hospitals are hesitant to do the transplants. And nowadays, recently, they have put forth a requirement that only hospitals with full NABH can do transplants because it is a high-end procedure. That is one problem that we faced. And we have not been doing transplants under CM scheme for the past 2 years. And it took our hospital at least 2 years for us to complete the NABH inspection. And only recently, before 1 month, we got that NABH full NABH approval, and only now we can do transplant under CM scheme. We did only once, sir, now recently.
The same thing will be applicable for the deceased donor also, no, sir?
Only one package. Only one package. Live or cadaver, they don't differentiate.
Now, this is for kidney, you were telling. Yes. Like that, for the liver and heart and all those things, it will be a little bit higher, no, sir?
Yes, sir. Yes, sir.
It will be higher and the ratio changes.
Yes, sir.
So that's why to know each and every section only, that's why we are conducting different meetings, sir. That is the main aim of conducting different meetings. So this month being the kidney donor day and all those things. So I thought of, and also you are also in our team. So I thought of having this kidney donor program as the theme for this month. That's why I have selected this, sir.
Yes, sir.
So it was a very nice discussion, sir. Any other thing you want to tell Balakrishnan, sir?
Nothing, Rajesh. Everything has been covered. Thank you for organizing this meet and making me also part of this meeting. Great.
Saravanan, sir, you know, no, sir?
Sir,
Yeah. We know.
Sir, it's my teacher, sir. Balakrishnan sir was my teacher in my PhD, sir.
Okay. Sir, Kanagachala Kumar, sir, வேற ஏதாவது general surgeon view இருந்து ஏதாவது question கேளுங்க சார். Doubts, sir. உங்களுடைய experience இருந்து கேளுங்க.
Previously, we used to say that it has to be certified by 2 neurologists. Is it still exists, that rule? 2 neurologists has to certify the brain death. Dr. Saravanan is still holding?
It's there. It's there. Same.
2 neurologists.
Form போட்டேன் சார். ஒரு ஸ்லைட்ல ஃபார்ம் இருந்துச்சுல்ல 1 2 3 4 அதுல வந்து ஒன்னு வந்து ஹாஸ்பிடல் அத்தாரிட்டி சைன் பண்ணலாம் சார். ஹாஸ்பிடலுடைய மெடிக்கல் சூப்பரண்டோ மெடிக்கல் டைரக்டரோ சைன் பண்ணலாம். ஹாஸ்பிடலுடைய அனஸ்தட்டிஸ்ட் சைன் பண்ணலாம், இன்டென்சிவிஸ்ட் சைன் பண்ணலாம். மீதி ஒன்னு வந்து நியூராலஜிஸ்ட், இன்னொன்னு நியூரோ சர்ஜன். இந்த நியூராலஜிஸ்டும் நியூரோ சர்ஜனும் அவங்களுடைய டிகிரி குவாலிஃபிகேஷன் இருந்தால் மட்டும் சைன் பண்ண முடியாது சார். அவங்கள ஆல்ரெடி நம்ம வந்து டிரான்ஸ்டானுக்கு வந்து அனுப்பிச்சு அவங்களுடைய டீட்டெயில்ஸ்லாம் அனுப்பிச்சு அவங்களுக்கு ஒரு எம்பேனல்மெண்ட் ஐடி கொடுக்குறாங்க. அந்த இஎம்பி அப்படின்னு வருது. அந்த இஎம்பி ஸ்லாஷ் எந்த இயர் வாங்குறோமோ, இப்போ சப்போஸ் இந்த இயர் வாங்கினோம்னா 24ன்னு வரும். அதுக்கப்புறம் ஸ்லாஷ் போட்டு ஒரு நம்பர் கொடுக்குறாங்க. அந்த இஎம்பி ஐடி இருந்தால் தான் அவங்களுடைய சிக்னேச்சரை மட்டும்தான் நம்ம அந்த ஃபார்ம் 10ல வந்து பிரெயின் டெத் சர்டிஃபிகேஷன்ல போட முடியும் சார். அவங்களுக்கு இஎம்பி ஐடி இல்லைன்னா நம்ம போட முடியாதுங்க சார். நம்ம ஊர்ல ஒரு 10 பேர் இருக்காங்கன்னா எல்லா நியூராலஜிஸ்டும் சைன் பண்ண முடியாது.
Oh, that's a new news, Saravanan.
So for that, that's what, sir. இப்போ அதுதான் இந்த மாதிரியான பாயிண்ட் வந்து டிஸ்கஷன் நீங்க இப்ப சொன்னது. இப்போ வந்து இட்ஸ் a நியூஸ் ஆக்சுவலி. ஜெனரலா வந்து நியூராலஜிஸ்ட் நியூரோ சர்ஜன் சொல்லிட்டு இருந்தாங்க. ப்ரீவியஸ்லி we were just called in. நாங்கெல்லாம் வந்து கவர்மெண்ட் சர்வீஸ் இருக்கிறப்போ 2001ல இருந்து 2004 வரைக்கும் I was in government service. At the time இந்த எம்பேனல்மெண்ட் இதெல்லாம் ஒண்ணும் கிடையாது. What they used to ask, கவர்மெண்ட் டாக்டர் வரணும்னு சொல்லிடுவாங்க, கவர்மெண்ட் டாக்டர் வருவாங்கன்னு சொல்லிட்டு வந்து சைன் பண்ணுவாங்க. That's what. Now even for government doctors, any restriction is there or not? That is my question now.
சார், அதாவது இந்த எம்பேனல்மெண்ட் ஐடி வாங்குறதுங்கிறது ஒவ்வொரு ஹார்வெஸ்டிங் ஹாஸ்பிட்டலுடைய ஒரு ஜாப் டிஸ்கிரிப்ஷன் ரெஸ்பான்சிபிலிட்டி. இப்போ நான் வந்து அபிராமி கிட்னி கேர்ல இப்போ சார் சொன்ன மாதிரி ஆர்கன் ரிட்ரீவல் சென்டரா நான் வைக்கணும் அப்படின்னு நினைச்சேன்னா, நான் வந்து எனக்கு விசிட் பண்ற நியூராலஜிஸ்ட் நியூரோ சர்ஜன் அது இல்லாம இன்னும் 4-5 பேர்த்த எம்பேனல்மெண்ட் ஐடி வாங்கி வச்சிருந்து அந்த 4 சிக்னேச்சர்ல 2 சிக்னேச்சர் அந்த நியூராலஜிஸ்ட் நியூரோ சர்ஜன் கிட்ட எழுதி அதுல கீழே அந்த இஎம்பி ஐடி எழுதினா தான் இட் இஸ் அக்செப்டட் ஃபார் பிரெயின் டெத் டிக்ளரேஷன் சார்.
That's what, sir. So we have to take the form from the transplant and then fill it up and then do the procedure.
Yes.
That's what we need to do it and keep it ready.
We need more and more organ retrieval centers across Tamil Nadu, sir, to facilitate the brain death donor declaration.
Sir, how to improve the retrieval centers, sir, more?
Sir,
what is your idea?
Whichever centers are doing transplantation, avanga mattumda they have been registering for to be the retrieval centers. If most of the government medical colleges have already received information and orders from this center. இப்போ இது வந்து எந்தெந்த ஹாஸ்பிட்டல்ஸ் எல்லாம் வந்து அதிகமான ஐசியூ ரோட் டிராஃபிக் ஆக்சிடென்ட்ஸ் டீல் பண்றாங்க, எந்த ஹாஸ்பிட்டல்ஸ்லாம் வந்து ஒரு நியூரலாஜிக்கல் எமர்ஜென்சிஸ் டீல் பண்றாங்களோ அவங்கெல்லாம் தே ஹாவ் டு கம் ஃபார்வர்ட். அவங்களுக்கு வந்து ஐஎம்ஏ ஹேஸ் டு ட்ரிகர் தேர் இன்புட். தே ஹாவ் டு ரெஜிஸ்டர் வித் டிரான்ஸ்பிளான்ட் அபவுட் ஆர்கன் ரிட்ரீவல் சென்டர். அதுக்கு வந்து டிரான்ஸ்பிளான்டிங் சென்டர் தான் அது ரிட்ரீவல் சென்டரா இருக்கணுங்கிற அவசியம் இல்லை. எனி சென்டர் வித் தேட்டர் மினிமல் ரிக்வயர்மெண்ட்டா அவங்க ஆப்ரேஷன் தேட்டர் கேட்பாங்க அண்ட் இன்டென்சிவிஸ்டோட ரோல் கேட்பாங்க. இது ரெண்டும் இருக்கிற பல சென்டர்ஸ் வந்து ரிட்ரீவல் சென்டர்ஸா நாளைக்கு டெவலப் ஆகி ரெஜிஸ்டர் ஆச்சுன்னா இந்த ஆர்கன் டொனேஷன் பிரெயின் டெத் டிக்ளரேஷன் வில் பி இன்க்ரீஸ்ட். அதெல்லாம் விட ஃபர்ஸ்ட் அண்ட் ஃபோர்மோஸ்ட் சார், எனி ஐசியூ பேஷண்ட் இஸ் ஆன் கோமட்டோ ஸ்டேஜ் ஃபார் மோர் தென் 48 hours. Please look for IMA has to make the intensivists and the treating doctors to look for signs of brain death. If the brain death is there, please do an apnea test. If the apnea test is positive, நம்ம உடனே அந்த அட்டண்டர்ஸ் கிட்ட நீ வந்து பிரெயின் டெத்னு சொல்லிட்டா அவங்க அட்லீஸ்ட் அவங்களுடைய ஃபினான்ஷியல் ரிசோர்சஸ் வேஸ்ட் பண்ணாம தே கேன் அட்லீஸ்ட் டேக் ஹோம் தி பேஷண்ட் இஃப் தே ஆர் வில்லிங் ப்ரொசீட் ஃபார் ஆர்கன் டொனேஷன். Only then the economic resources need not be wasted and the organs also need not be wasted.
Sir, that is a very nice idea, sir. That's why we are having a meeting like this. The only thing is, what my request is for you is, since you are a nephrologist or all those things, you first initially you do in E-Road at least, identify which are all the hospitals that can be taken for this retrieval. First you start from your place. Like that, in each and every city, we will try to identify the centers which are all the retrieval centers. And then we will try to tell them, we will have a meeting of all the people, like a zonal meeting I was telling. We will have a meeting of the people and we will start doing it. Okay, sir? So my request is, you first start do in your city. Like that, if you know any one of your friends nearby places, you can tell this man can take charge of it and then do it. We will have a meeting at the end of 1 or 2 months, and then we will have a discussion, and then we will finalize which are all the teams, hospitals we need to get the retrieval to make them as a retrieval centers.
Okay, sir.
You please get a list. We will try to do it, sir.
Thank you,
like
sir.
that we will start doing. That is my request, sir.
Sir, thank you, sir.
கனகராஜன் குமார் சார், நீங்களும் அதே மாதிரி தான் கொஞ்சம் ஈரோட்ல இருக்கிற சென்டர்ஸ்ல எந்தெந்த சென்டர் வந்து ரிட்ரீவல் சென்டரா பண்ண முடியும் அப்படின்னு சொல்லிட்டு நீங்க திங்க் பண்ணுங்க. That is what. பாலா சார், நீங்களும் அதே மாதிரி கோயம்புத்தூர்ல நம்ம எந்தெந்த சென்டர்னு சொல்லுங்க. நம்ம அந்த சென்டர்ஸ் எல்லாம் நம்ம திங்க் பண்ணி we will also create. These are all the ideas to create it. இப்போ சரவணன் வந்து இந்த ஐடியா கொடுத்தாரு. சோ அந்த ஐடியா வச்சு நம்ம வந்து பில்ட் அப் பண்ணணும். That's the main idea of doing it. So any other questions from the audience? There was one question, something like that. We will see any question is there in the chat box.
Yeah, it's very difficult to detect a parathyroid adenoma in a donor. Even in a normal individual, if you meticulously look for only, we will be able to screen, detect, and find out. And if there is a parathyroid adenoma, I don't know, because it's a totally different scenario. The patient is detected to be a brain dead donor, and we screen for the routine things. And generally, parathyroid adenoma is not looked into. So I don't know how to answer for this one. And generally, if there is a hypercalcemia and other existing comorbid conditions because of the hyperparathyroidism, then it may be true. Otherwise, I don't think so. It's a absolute contraindication for donation.
Okay, sir. Then one more question. Any absolute contraindication for transplant?
Absolute contraindication for transplant. If for the recipient or for the donor?
They generally asked. Any absolute contraindication for transplant?
I'll come for the recipient this thing. If they have an active malignancy or any active infection, or if they are psychotic, where they will not be able to take their medications regularly, or they may not be able to take care of themselves, or if they have severe atherosclerosis of the peripheral vessels, where it may be difficult to anastomose the donor vessels to the recipient vessels. These are all the absolute contraindications for transplantation.
Balakrishnan, to add one more thing, any gross bleeding diathesis?
Yes, sir. Welcome. Yeah.
Because we are doing the anastomosis. If it continues to bleed, then there is a big problem. And then probably primary oxaluria, isolated kidney transplant may not be possible. You may have to do both liver and kidney.
Liver and kidney. Yes.
Both together.
Yeah.
Otherwise, the graft kidney is going to get repeated stone formation.
One more question, sir. Is pancreas transplant successful in diabetes? Is pancreas transplant successful in diabetes?
Yeah, it's successful in diabetes, but anyhow, it also has to be, the surveillance has to be there for any rejection and other things, and it has to be monitored. That's a very great task.
We will see any other question.
Rajesh, well coordinated and very useful webinar, I would like to say. And I would like more people to put their opinions, questions in the chat box, and in the future, they can make it much more interactive. So all the panelists were able to do the job very well, and hope most of the people informed reasonably get benefited. So well done, Rajesh. All the best.
Sir, only thing is, as we were discussing, myself and Balakrishnan sir were discussing to get the retrieval centers. You please coordinate with some of the people in Erode, nearby places, and all those things.
Oh, yes.
To make more of the retrieval centers,
We can.
so that we will be able to. No. What my suggestion is, we will take this as an opportunity, and we will try to get more of the retrieval places. Because you know a lot of friends and a lot of places you are the consultants. So you can try and do it, sir. That's why you also can start identifying the places where they have the intensive care unit and intensivist team. We can try and do it, sir. That is what my request, sir. Please help me, sir.
Okay. We will coordinate.
Yes, sir. We will do it, sir.
All the best, Rajesh.
I think there are no other questions from in the chat box. I think already the discussion was there more than 2.5 hours to 2 hours 45 minutes. I think we can close this session. I request Dr. Kanagachala Kumar sir to give the vote of thanks.
Thank you, Rajesh.
Thank you, Vandal.
Thank you, Vandal. Thank you, Rajesh.
Again, a very good evening to everyone. Yes, sir. I thank Dr. Rajesh Babu for organizing such a wonderful meeting. It was very nicely discussed and interacted by the participants. I thank our state president, Dr. Abul Hassan, for giving the presidential address. And I thank Dr. Sengutuvan sir and Dr. Karthik Prabhu for the felicitation, and also Dr. Gauri Shankar for participating in this. I thank Dr. Saravanan for giving a detailed lecture on the nephrologist perspective, and Dr. Ramalingam sir as the urologist role. Both the topics are well covered. Many new points are discussed. It was very useful. I thank the chairpersons, Dr. Sendil sir, urologist, and Dr. Balakrishnan sir, nephrologist, for their wonderful interaction and guidance. I thank Mrs. Devi Subramanian and Mr. Muhammad Shahir of Jammu Hospital for being part of the team. I thank all the participants, mainly 350 participants were there. It was really a wonderful meet. I thank again Dr. Rajesh Babu for the nice organization of this meet. Thank you, one and all.
Thank you, sir.
Thank you.
Thank you, Balakrishnan.
Rajesh, congrats. நல்லா பண்ணிட்டீங்க.
சார் வணக்கம் சார், சுகுமார் சார்.
வணக்கம் சார், நல்லா பண்ணீங்க. கடைசியில ரொம்ப தமிழ்ல வேற பேசிட்டாரு, அது ரொம்ப நல்லா இருந்துச்சு.
யாரு?
சரவணன் கொஞ்சம் தமிழ், சரவணன் தமிழ்ல பேசினாருல, ரொம்ப குஷியா இருக்கும் தமிழ்ல கேட்டோம்னா.
தேங்க்யூ சார்.
இல்லைங்க சார், எல்லாருமே அவங்க டீம் அவர் வந்து ரொம்ப இதா சொல்லிட்டே இருந்தாரு. அதனாலதான் நான் வந்து
பார்த்தேன், கேட்டேன். எல்லாமே டாக்டர் ராமலிங்கம் எல்லாமே நல்ல பாயிண்ட் பை பாயிண்ட் எல்லாம் சொன்னாங்க. எல்லாம் நல்லா இருந்துச்சு.
Rajesh,
சார் சொல்லுங்க.
in an organ donation meeting, it will not be a complete when there is no talk on blood donation. So Dr. Sumar is known for his blood donor activity.
நெக்ஸ்ட் மீட்டிங்ல அது போடலாம் சார்.
Okay.
பிளட் டொனேஷன் பத்தி ஆட் பண்ணிடலாம் சார். ஆர்கன் டொனேஷன் பிளட்டும் சேர்த்து தான் சார்.
அதனாலதான் சுகுமார் சார் இல்லாம அந்த மீட்டிங் கம்ப்ளீட் ஆகாது.
நெக்ஸ்ட் மீட்டிங் பிளட் டொனேஷன் போட்டாலே முடிஞ்சது. நான் பிளான் பண்ணிட்டு சொல்றேன்.
போட்டலாம்.
ஒன் பை ஒன் how to improve it, how to develop it ன்னு சொல்லிட்டு போடலாம் சார். நீங்க எல்லாம் வந்தது ரொம்ப நல்லது. தேங்க்ஸ் சார். நீங்க எல்லாம் அட்டெண்ட் பண்ணதே ரொம்ப சந்தோஷமா இருக்கு.
சரி பரவாயில்ல, பார்ட்டிசிபென்ட் பாருங்க எத்தனை பேர், 300 பேருக்கு மேல போயிடுச்சு.
350 பேர் சார்.
அதான் சரி. ஆனாலும் எங்க அந்த காலத்துல எங்க மாமா பெரிய பொட்டு வைக்கிற மாதிரி கணக்கு பயங்கர பொட்டு வச்சுட்டாங்க. எங்க மாமா ஒரு எம்எல்ஏ இருந்தாங்க இந்த காலம், இங்க பயங்கர பொட்டு வச்சிருப்பாங்க. அது அந்த அளவுக்கு சைஸ் வச்சுட்டீங்க இன்னைக்கு.
எப்பவுமே போட்டு இப்படிதான் வச்சுட்டு வருவாரு.
இல்ல வச்சிருப்பாரு, குங்குமணிக்கு ரொம்ப நல்லா பெருசாவே நல்லா இருக்கு. பேஸ் மட்டும் தானே தெரியுது, இல்ல அப்படியே குங்குமம் பெருசா இருக்கு.
இல்ல அது எல்லாமேங்க கொஞ்சம் ஸ்வெட் ஆனா குங்குமம் அப்படியே கொஞ்சம் பெருசாயிடும். ஸ்வெட்டிங்ல நனைஞ்சு காலையில சின்னதாகிற ஈவினிங் ஆகுறதுக்குள்ள பெருசாயிடும்.
சரி சரி.
Thank you so much sir. We will leave sir. Thank you sir.
Thank you Rajesh.
Thank you
nice
sir.
meeting.
Thank you so much.
Wonderful.
சரிங்க ராஜேஷ், பாப்போம். பை.
Thank you sir. Thank you sir.
Thank you sir.
தேவி மேடம் நல்லா பேசுனீங்க.
Thank you sir. Thank you for
நல்லா நீங்க இன்னும் ரொம்ப பாயிண்ட்ஸ் சொல்லணும். நீங்க எல்லாம் ரொம்ப பாயிண்ட்ஸ் கொடுத்தீங்கன்னா தான் நீங்க ஜெனரலா நீங்க என்ன பண்றீங்கன்னு அதை அப்படியே சொல்லிட்டு, உங்களுக்கு இங்கிலீஷ்ல பேச வரல தமிழ்ல பேச வேண்டியதானே சார். ஒரு பேஷண்ட் வந்தவொடனே அட்டெண்டர் கிட்ட பேசுவோம் சார், அட்டெண்டர் கிட்ட பேசிட்டு இந்த ஃபார்ம் ஃபில் பண்ணுவோம் சார், அந்த ஃபார்ம் ஃபில் பண்ணுவோம் சார், லைன் அப்படியே சொல்லிட்டே வர வேண்டியதாங்க. வெரி சிம்பிள் தாங்க இது. பேசி பழகுங்க.
எல்லாருமே இருக்கிறதுனால கொஞ்சம் யோசிச்சேன்.
இல்ல பெரிய டாக்டர்களா இருந்தா அதை பத்தி எல்லாம் கண்டுக்கூடாதுங்க. நீங்க பாட்டுக்கு நீங்க என்ன சொல்ல வரணும்னு நினைக்கிறது சொல்லிட்டே இருக்கும். மீட்டிங் 5 மணிக்கே முடிஞ்ச மாதிரி இருந்தது. இப்ப இது வரைக்கும் நான் எப்படி எடுத்துட்டு வந்தேன்? எவ்வளவு கேள்விகள் கேட்டுட்டே வந்தேன். உள்ளே யாரையுமே உள்ளே எல்லாரையுமே பேச வச்சுட்டு
கண்டிப்பா
அந்த மாதிரி தான் நாம நம்பி பேசிட்டே இருக்கோம்.
கண்டிப்பா நெக்ஸ்ட் டைம் யூஸ் பண்ணிக்கிறேன் சார்.
நெக்ஸ்ட் மீட்டிங் இதெல்லாம் ஜாயின் பண்ணுங்க. நீங்க ஜாயின் பண்ணி நீங்க அப்படியே நல்லா growth பண்ணணும். இப்போ நான் சொன்ன மாதிரி நீங்க என்ன பண்ணணும்னா, only thing is you have to identify the retrieval centers. நம்ம கோயம்புத்தூர்ல யார் யாரெல்லாம் retrieval center கொண்டு வரலாம்னு சொல்லி retrieval centers எதெல்லாம் கோயம்புத்தூர்ல இருந்து கொண்டு வரலாம் அப்படின்னு சொல்லிட்டு திங்க் பண்ணுங்க.
ஓகேங்க சார். ஓகே,
நீங்க திங்க் பண்ணி அது ஒரு லிஸ்ட் இருந்தா எனக்கு அனுப்புங்க சார். இந்த ஹாஸ்பிடல் எல்லாம் நல்ல டெவலப்மெண்ட் இருக்குங்க சார், அவங்க ஐடியா எல்லாம் retrieval ட்ரை பண்ணலாம் சார். I think only when we improve the retrieval centers more, then only we will get more organs. இல்லன்னா எல்லா இடத்துலயுமே people started having intensivist இருக்குது, ICU வச்சிருக்காங்க, ஹெட் இன்ஜுரி எல்லாருமே ட்ரீட் பண்றாங்க, பிரெயின் டெத்ஸ் ஆட்டோமேட்டிக்கலா ஆகுது. ஸோ நாம அந்த லெவல்ல போய் பண்ணாதான் நம்ம we will get more of the donations. So that's what we need to do. அதனால retrieval centers யார் யாரெல்லாம் பிடிக்கலாம் அப்படின்னு சொல்லிட்டு நீங்க சொல்லுங்க. நம்ம அந்த retrieval centers எல்லாம் நாம ஐடென்டிஃபை பண்ணி retrieval centersக்கு எப்படி ரெடி பண்றதுன்னு சொல்லி we have to get it. That is the thing.
Okay sir. Thank you sir. Next time we can sir.
Thank you madam.
Thank you.
Thank you.
ஒண்ணுமே இல்ல லட்சுமி.
என்னது?
அவ பொண்ணாட்டுக்காரா வந்து இல்ல சொல்றேன் பொண்ணாட்டுக்காரா நிறைய பேர் பஸ் வைக்கிறேன். தண்ணி
கூட்டு வந்தாச்சா?
then hasta que